Today we have a special guest, Dr. Deirdre Conroy, who is going to help undercomplicate the topic of sleep restriction therapy, or SRT. So welcome to Undercomplicating Stuff, where we, two psychologists and coaches with over 40 years of combined experience, share our insights to help undercomplicate important topics. A friendly reminder that this video is meant for entertainment and conversational purposes only. Please see the information section of this video for additional resources. So I'm Dr. Julie Radico. I'm a psychologist, a coach, an author, and a speaker, and I'm here with Dr. Stacey Gedian.
Hi, Stacey Gedian. I'm the founder and CEO of a healthcare consulting and professional coaching business and a health psychologist by training. And Dr. Deirdre Conroy, please introduce yourself before we get started.
Thank you, Stacey. My name is Deirdre Conroy. I'm a clinical sleep psychologist and I'm in private practice and I work predominantly with sleep disordered patients.
And we have so much that we want to ask you about sleep restriction therapy. And starting with, can you describe what is meant by it?
The term sleep restriction therapy is often quite alarming to a lot of people, especially people with insomnia, because the initial reaction is, well, I'm already sleep restricted. Why would I go through a therapy that would sleep restrict me even more? And I think over the years, this has taken on different understandings. So when sleep restriction therapy was first created, the idea was that the intention of the therapy was to improve the consolidation of one's sleep by asking someone to spend less time in the bed. We develop insomnia so often what we do is we try to fix it. And we try to fix it by spending more and more time in the bed. But what happens when we spend more and more time in the bed is that our sleep starts to break apart into pieces. And you wind up having fragmented sleep night after night. So the original experiment was done by my advisor, actually, Dr. Art Spielman in 1987. And what he did was recruited people with insomnia and had them collect sleep diaries and got an understanding of how much time on average people were spending in the bed compared to the time they were actually spending asleep. And the assignment really with this research was, I want you to only spend the time in the bed that you're actually sleeping. And what they found was that scores of insomnia improved. So their subjective perception of sleep improved, but also something called sleep efficiency, that is the percentage of time that you slept in the bed, also improved. So this became the preliminary model of one of the key interventions in cognitive behavioral therapy for insomnia.
I imagine when talking with clients and you bring up the word restriction related to their sleep when they're already struggling, they're like, what are you talking about? I need to try to lay in bed as long as I can and get my body to just fall asleep and just will it to happen and force it. And what we know is that humans are complicated. The way our systems work and the way we associate things knowingly and sometimes unknowingly can really do us a disservice. So I'm hearing you say that restriction is like really specifically trying to help your mind recognize that when you see your bed, it should be helping you sleep rather than thinking about laying awake in bed.
It does that. It does two things. So one of the other things I will talk to my clients about is how sleep is regulated. And I spend a lot of time talking about there's this model called the two-process model. One process is our sleep drive system, which basically means the longer we go without sleep as the day goes on, there is a sleep debt that accumulates across time. And if I go to bed a little bit later, so therefore I'm staying up, I'm spending less time in bed, I'm going to have a more sleep drive in my system. So physiologically, I'm going to have more sleep drive. And then when I go to bed, I'm more likely to fall asleep and stay asleep in the bed. And also, the other thing that you mentioned is that association with the bed and sleeping that also can improve as well, because when I go to bed, I'm going to be so sleepy that I will fall asleep and stay asleep, hopefully faster.
How do you determine like the bedtime and wake time if you're thinking about SRT?
One of the things that we use as a tool is a sleep diary. This can be challenging for some people because it really does ask you to track what you're dreading the most, right? You're having trouble with sleep. I don't want to think about it every day, but it really is our only tool. We don't have a test. We don't have a blood test for insomnia. We can't understand it in many other ways other than asking you to start tracking your sleep. So most programs programs will ask the client for a week, at least 5 days. I want you, when you wake up, I want you to either enter in an app or paper and pencil. What time did you go to bed? What time did you wake up? How long did it take you to fall asleep? How long were you awake for? And you're guessing, you're just guessing about what happened. This might not be the truth and not always relying on a wearable. We can talk more about that. But it is asking the client to every morning when you wake up, can you jot down a few notes about your sleep? And now we have so many great apps out there that can calculate on average, how long did you spend in bed, which is basically the bedtime to the rise time, we call it, the time that your feet are on the floor and you're starting your day, versus how many hours of sleep did you actually get? And so again, we get the average, and I enforce the average because it's not just one night of poor sleep. It's really, we're getting a snapshot of all the days combined.
Definitely helpful information. And one thing I'm also hoping you can address is when people hear the term sleep restriction or time in bed restriction, I feel like that was sort of a relabeling or rebranding to make it sound a little bit better, but it's true.
Mhm.
And folks say, but don't I need 8 hours of sleep? Isn't that what I'm supposed to get to function well? And I wonder what you tell people when they bring up that question.
Well, first, I want to say that that is such a common complaint slash question slash comment or caveat. And when I start to explain the process of time in bed restriction, they'll say, no, my doctor told me that I need to get 8 hours. And that's the number. And that's the number that I would like. And that can be tricky because sometimes I'll kind of say, well, okay, how are you going to do that? Can you snap your fingers? Can you will yourself to tonight get 8 hours of sleep? And the answer is, save for taking a medication, is usually not. We usually can't say, this is the number I'm going to get tonight. We just can't control it. So the process really is, how can we improve the quality of the sleep that you're getting right now? And let's say, for example, someone's coming in with 6 hours of sleep and they're saying, I desperately want more than this. We'll say, okay, let's just optimize those 6 hours, get you sleeping on a regular schedule, get your sort of behaviors cleaned up, and then we can add on to that time. So there still is opportunity to expand the total sleep time to, if the goal is 8 hours. But we also will spend time in later sessions in the program to talk about this belief that everybody needs 8 hours of sleep to function well during the day. And we know from various research studies that that's not true for everyone. And there's huge individual variation from person to person with respect to how many hours of sleep we need.
So I'm hearing you describe for our listeners that one of the steps for this therapy is to track the sleep that you're getting, like doing a log and seeing like what are the average amounts of sleep that you're actually getting. How do you help people figure out how much they're supposed to be sleeping? Like, how would I know if I'm somebody who needs 8 hours, 7 hours, or like 9.5 hours as like what I should be getting?
Great question. So how do I know how many hours I need to function well during the day? And this is a very tricky question because we don't sleep in a bubble. I mean, there's so many influences on our sleep and our environment, whether that's physical environment or relationships and our work. But my main question is always, well, how are you feeling during the day? When we start working on sleep and experimenting with different numbers of hours of sleep, we're always asking, okay, well, how did you feel? And in some cases, in certain situations, we might do something called sleep satiation, which is you ask someone if you have an opportunity to take a week off or 2 weeks, which again, rare circumstances, at least in the people I talk to. But if you can, what would it be like if you were allowed to sleep when you wanted to or sleep ad lib? Does that make you feel better? And eventually you kind of get a sense of what your body and brain is doing over time and closer to what that number is. But it can be tricky to say, I've discovered this one number, because the truth of it is we feel differently every day. And truth, we also sleep differently every night. And I think what I hear a lot in clinic is people who want predictability. I want to feel this way every day. And I want that to be predictable. And I want to sleep a certain way every night. And so we spend a lot of time moving towards acceptance that there are these variability, these there is this variability in our felt state.
Thank you for bringing up the point about really focusing on how we feel versus the number, because that's really what it's about. And I can even speak personally. There are nights when I don't sleep as much, but I feel better than other nights where I feel like I slept more. And so, to your point about there being so much variability and so many other factors that come up, I'm also curious. So, when clients come in and they say, well, but the weekends, certainly I can sleep in on the weekends, or I want to catch up on my sleep. What do you say to people who really want some variability while they're going through sleep restriction therapy?
Yes. So for those people who are either, working during the week and they have different schedules during the work week versus weekend, it's really interesting when I'm going through this program with someone and they're on board and we've just decided on a sleep-wake schedule that they're going to keep, and then they'll say, and I'll say, oh, also on the weekends, if that changes, oh no, I can't. No, the weekends are sacred. This is my catch-up time. This is a door to have another conversation about really what are we doing when we're catching up on sleep. And it's so common. And for many people, it can be helpful catching up on the weekends. And for some people, it doesn't affect their upcoming week at all. But for other people, when we quote sleep in, usually that means that we're sleeping later. This is an opportunity in the session to talk about something called a circadian rhythm. So we are built with this internal clock, and it's important for our sleep to keep kind of a regular schedule, waking up around the same time each day. But when we sleep in later on the weekends, we're shifting our body clock later. It's almost as if we're flying to another time zone on the weekends. And we know from anyone who's traveled to another time zone, we get something called jet lag. So you may inadvertently be jet lagging yourself in a way if you're sleeping later, which then I'll say, what's Sunday night looking like for you? Oh, I hate Sunday nights. That's when I get the dreads for the upcoming week. Well, let's talk about why that might happen. And you might have shifted your body clock. So I go through this explanation about the whys and the biology of the disadvantage of sleeping late on the weekend so that the client understands why I'm asking them to get up early. In some cases, it might be much earlier than they typically wake up on the weekends, and why we're doing that and why that would help during the upcoming week.
As you're talking, one of the things that's coming to mind for me is this term that I've heard recently of revenge sleep time procrastination. So this like, I don't want to go to bed. I want to claim my time in the evening or like before I'm, supposed to go to bed. And that procrastination around sleep can really affect how you feel the next day or kind of continue this really unhealthy cycle that you might get stuck in related to your sleep. So I'm really curious as we talk about this, really try to help listeners understand what all of the different like terms are and getting a better sense of just what does their sleep really look like? How can they be sort of like objective with their sleep to be like a scientist? Because I'm hearing you say you want to gather good data to make good informed decisions about what's healthy for you. And SRT sort of helps you with that. And one of the things that I often hear from clients that I work with is just this sort of like using the same terms interchangeably when they might not mean the same thing. And one of the examples that comes to mind is this idea of people who talk about being sleepy and talk about being tired and how those two things are actually different. And I'm wondering if you could expand on that a little bit.
Yes. So the difference between sleepiness and tiredness is almost always a conversation I will have as I start implementing a sleep treatment program. So first I'm going to explain what the differences are and then why that's useful. So the difference between sleepiness and tiredness is, let's start with tiredness. Tiredness is more of like a fatigue, low energy. I feel like I just want to rest my body. Sitting may help. Low energy. Sleepiness, on the other hand, is I feel as if sleep is near. I am about to doze off. I'll often ask, do you ever remember dozing off in school or you're at a boring meeting and your eyes are just kind of dipping? That's sleepiness, not necessarily tiredness. Now, you can have both, but it is important to understand the difference between them because with sleepiness, let's start with that. If I'm chronically falling asleep during the day. I can't keep my eyes open. I'm falling asleep at my job. The next line of questions for yourself is quality or quantity of sleep. So, starting with quality, is there anything disrupting my sleep? Am I waking up with any unusual events? Am I snoring, gasping, choking? Is anything happening biologically in my sleep that might be compromising the quality? And furthermore, that's sort of like, do I need a sleep study? Do I need to talk to my doctor about this? Because usually the compromises to my sleep quality might be something medical. So that might indicate, do I need a sleep study? So quality, quantity. Am I chronically not getting enough sleep because I'm too busy? I'm just doing other things, and maybe I get involved in a project late at night, or someone's calling me in the middle of the night, and I'm not allowing myself to get enough sleep. Those are indicators that something might be contributing to sleepiness. Knowing when we're sleepy is really important because one of the guidelines in the treatment for insomnia is I only want you to decide to go to bed when you feel sleepy. And so understanding what that means for you internally is like, oh, that's when my eyes start closing. But I'll tell you that a lot of times in my experience in both in research, individuals with insomnia haven't felt this in years. There's usually this like hyper arousal, go, 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 go. And they're like, sleepiness, I don't know what that is. So the idea here for a provider or if you're just someone struggling with insomnia is like, what would it be like if I stayed awake until I'm sleepy, until I actually got that sensation that I'm about to fall asleep? That's what we're looking for. It's in there somewhere. We just have to harness it. So that's the sleepiness. Now, tiredness slash fatigue in my mind can reflect so many things. And I'm sure, you talked to a lot of people on this podcast about all kinds of other medical disorders, psychiatric disorders, products of medications. There really is a wide variety of things that can contribute to fatigue and tiredness, and we might want to address them somewhat separately.
Very helpful information to differentiate between sleepiness and tiredness. And I know I've heard you in other settings talk about tired but wired and how that is different from sleepiness. And then I'm also thinking our clients or people who struggle, I should say, with insomnia in general, typically live with other people. And they can live with people who want to be really supportive. And so let's say they're in a sleep restriction program with sort of a delayed bedtime, and they're feeling sleepy much earlier as they're starting this process, and their loved one says, well, just go to bed. If you're sleepy, go to bed, meaning to be helpful. And I'm wondering if you could speak a little bit about how that might work against the person's improvement in sleep, as well as anything else that loved ones can either say or do, or maybe avoid saying or doing to help someone who's going through a sleep restriction therapy program.
Usually, when we ask about supports at home and someone says, "Oh, my spouse, they're so great, they're so concerned," usually you're thinking, "Oh, that's wonderful." Not so much in this program. I'll say, uh-oh, because of just what you said, Stacy, and that is usually the partner wants the best for their partner, and they'll say, "Oh, you're so sleepy. You've had such a hard time with your sleep. Just go to bed. Just go to bed whenever, or stay in bed, and why don't you take a nap?" These are all things that we start to discourage at the beginning of a treatment program. So while the partner is very well meaning and intentioned, sometimes I'll invite them into the session so that we can have a conversation together and say, for a short period of time, your partner will be intentionally staying up, even though they might be feeling sleepy. And we're doing this because X, Y, and Z. Or on the weekends, we want your partner to stay awake and explain why. So including them in this conversation and that it is actually helping, because it's true for the first couple weeks, it doesn't feel great. The client themselves might be complaining, like, what did they have me doing? This is terrible. So you want to sort of set those expectations. The other thing you asked about is what maybe should you not be saying? Another conversation I've had multiple times is, what are the conversations like in your house when you wake up in the morning? And they'll say, oh, they always ask me, how did you sleep last night? It's like always the question in the morning. And this is a person who's been struggling with their sleep for probably decades. That question triggers. So I will sometimes, what would it be like if you asked something else about the night? Or it's not to avoid the conversation entirely, but just for that person, it really does kind of continue this cycle of like, here we go again. This is terrible. I can't do anything about this. And I feel terrible starting my day. So maybe choose the conversations at the breakfast table more carefully.
Our loved ones, and we've all done this too, say things that we think are really helpful and they are not, or they make people doubt the progress that they're making, or it's hard. What SRT is asking you to do is, even if you are feeling sleepy at times, to stay within the parameters of the sleep restriction, because you want your body and brain to learn that you're expanding your sleep time in a more intentional way. And it's hard to do that. And so, really being thoughtful about joining your loved one in a supportive way of what they're doing in the most healthy way that this is going to be helpful. And I'm curious because I think that sometimes loved ones say things that are sort of missing the mark. It's because maybe they're not fully grasping like the heart of what's happening and why. And so if you could share like a Cliff Notes version, somebody's driving by a billboard and they're like, SRT, is it good for you? Like what's like the core pieces of SRT, and how would I, maybe as somebody who is struggling with sleep, know that it might be a good thing for me to try?
Along the lines of a billboard, I almost want to go with that old-fashioned like short-term pain for long-term gain kind of slogan. It's really not sleep restriction. This is a misnomer. You're changing your behavior. It's a time in bed restriction, but really it will improve quality over time. It is a short-term intervention for a long-term payoff. It is not necessarily harmful. I think that's a lot of times what people will be concerned about this, that I shouldn't be doing this for XYZ reasons. This is not necessarily a cliff note, but there's a lot of research behind this in many other chronic medical conditions and psychiatric conditions that show that subjective impressions of sleep improve over time. So it has grown legs over time in terms of sleep restriction therapy. I think people have access to a lot of information right now about it, and that might perpetuate the stereotypes like, oh no, I don't want to do that kind of thing. But it really is still kind of a tried and true kind of intervention that we have that we know kind of works in a short-term manner. If you're starting off and you just want a few key elements of this, if you don't want to either dive straight into sleep restriction therapy or time in bed therapy, some key things that you can start kind of dipping your toe into. Number one, what would it be like if you just got up at the same time every day? You set that alarm, even if you don't have anywhere to go, and just kind of set that, we call that the anchor. What if you anchored yourself and your awake time to around the same time each day? And then maybe in the evening, start paying attention to sleepiness versus tiredness. Am I falling asleep before bed, or am I going to bed because I just feel tired, or I'm tired of the day and I want it to be done? Keeping in mind this regularity and schedule, and then also kind of what your experience is of sleep. Even if you don't have a chance to work with a provider or to do a sleep log or any of these kind of things that you'll see in an app, you might not want to dive into that completely, but there are a few key things that you can start monitoring.
The rationale behind why this works to help people improve sleep.
So in general, what we're saying here is changing your sleep schedule or limiting the time that you are spending in bed, getting up. Perhaps you might have to stay up a little bit later, or perhaps you might have to wake up a little bit earlier as part of the time in bed restriction or sleep restriction program. There is a process called a sleep drive system where it basically, you think about when you wake up in the morning, your sleep drive is very low. But as the day goes on, sleep drive, it also can be measured in a substance called adenosine in the brain, accumulates over time. And so let's say, I'm going to give you an example here. You have someone who typically goes to bed at 10 p.m. and they go to bed at 10 p.m. because that's just what time the household goes to bed. And that's just like what they think they should do. But they don't always feel sleepy. And they go to bed anyway, and it takes them some time to fall asleep and they struggle. In a sleep restriction therapy, their new schedule might be something like midnight. And you're asked, okay, so now I want you to stay up till midnight. What is going to happen at midnight, which wouldn't happen at 10 p.m.? As you stay awake longer to your new bedtime of, let's say, 12 a.m., you will have more sleep drive in your system. Sleep drive is correlated to a component of non-REM sleep called deep sleep or slow wave sleep. So increased sleep drive, increased slow wave sleep. Why is slow wave sleep or deep sleep important? This is the deepest stage of sleep that you can get, and it's also associated with more reports of feeling rested, a higher quality of sleep, and it usually happens in the first part of the night. The intervention biologically has been shown in many studies. When we look at the brain in a sleep lab and we've got you hooked up to an EEG, if you go to bed at 10 p.m., okay, you might take you some time to fall asleep. You have deep sleep, okay. When you stay up till midnight, might take you less time to fall asleep, and your slow wave sleep's going to be higher.
As you're talking about that, I'm wondering, who does SRT work for the most? Or like if I'm a listener and I'm wondering, like, is SRT appropriate for me? Like, how would they get a sense of, would it be helpful? Would it not be helpful? Specifically, like, what are the questions you would encourage people to ask themselves to know if they're a good fit?
So the fit is very important, and some questions that you on your own as a receiver of this information might ask yourself, or if you are working in the field and you're a provider. The first one that comes up for me is untreated bipolar disorder. So if you have untreated bipolar disorder and you are still experiencing bouts of mania, bouts of depression, we know that sometimes sleep deprivation, if that should happen, it's not always a consequence of sleep restriction therapy, but it can be that may increase the chances of a manic episode. So usually in bipolar disorder, that's not treated. Now, many people who have treated bipolar disorder come through the program and do just fine, but I would hesitate for untreated bipolar disorder. The other condition that I would use caution with is obstructive sleep apnea that is not treated, or any kind of sleep apnea. If you know that you have sleep apnea, particularly severe sleep apnea, and you're not on treatments like a positive airway pressure device, that may contribute to insomnia because you're waking up at night, difficulty breathing, and its own daytime sleepiness associated with that. The other condition I would say is seizures. There's been some research looking at sleep deprivation and the threshold for seizure-like activity. So I would be cautious in seizures. There's always modifications, and keep in mind we are just talking about one component of cognitive behavioral therapy for insomnia. There's many other components that you can benefit from. This particular one might not be it. And I'm going to throw in another one, which I find is more relevant for my practice, and that is high anxiety about sleep itself. And so many people are concerned about their sleep, and the idea of any type of restriction, regardless of the whys and the hows, that could elevate my anxiety. In fact, even doing a sleep diary can elevate anxiety. So if that to you is like out of the question, you couldn't imagine it, we might want to spend some time talking about the C in the cognitive behavioral therapy, the cognitive piece, reframing thoughts, using some calming activities, relaxation first before you even get to any kind of behavior change like that.
You know, I'm thinking about something we mentioned earlier about the naming of this program, sleep restriction therapy, and how recently there's been sort of a rebranding of it to time in bed restriction. And I'm wondering if you can speak more about what is actually happening and which term is most appropriate.
There has been a bit of rebranding, and I'm in favor of this. And you may hear terms like time in bed restriction or sleep efficiency training is another term that I've used as well. I think it's important to shift the focus away from this restriction per se, because I think it ends up being understood as sleep deprivation or that this is going to be dangerous in some way. And it really is more about the time spent in the bed. Now, can there be a result of some sleep restriction if you don't sleep well on one night, or sleep deprivation? But ultimately, that may be a side effect of the intervention, but not the goal of the intervention.
I'm really curious, what's the average time that it would take for like the sleep efficiency training to be effective on average?
On average, research shows that this time in bed restriction can take effect within 1 to 2 weeks. So you might think, oh, that's quite fast, unusual for any kind of psychological or behavioral intervention. That does mean that you are following it very closely. You are adherent. You're doing kind of all the things that you're asked to do, which is almost sometimes unusual because it's difficult and it can be quite rigid. But the research studies from which we discuss these findings are in people who are following this to the letter. So keep that in mind. But 1 to 2 weeks is generally the average.
You really have to stick to it for it to be effective.
Correct.
Lots of takeaways I could highlight today. The one that really sticks out, though, is if you know someone who is struggling with insomnia, it can be triggering to ask them, how did you sleep last night? And I really like that you brought that up and that maybe there's something else we could focus on so that it's not all about their sleep.
It really does depend on, what the flow of the conversation, asking about anything else. Did the dog bark last night? How was the temperature? But I'd also say for the person themselves that's experiencing insomnia, also being aware of what you're responding with. Like if you say, I didn't sleep at all or no sleep at all, asking yourself, is that true? Was there 1 minute of time that you lost during the night? And even recognizing that there might have been 1 minute that you don't remember could be encouraging. So the language we use is really important in our conversations about sleep.
I resonate with that a lot, and I imagine our listeners do as well. Sleep is such an important, heavy topic. And so my takeaway is there's just been so much really helpful information that you've shared. And I would encourage people to thoughtfully consider one change they could make. So if it feels overwhelming to say, I'm gonna, do sleep logs, download an app and track my sleep, make an average and start to restrict my time in bed and really follow that I'm sleepy rather than tired. Like there's so much good information, but if it feels like too much, picking one thing, and you said this earlier, Dr. Conroy, like that it's really like start with what feels manageable and doable for you, and to build on the idea of loved ones sometimes saying the wrong things, like have a conversation with the people in your household that this is what you're going to be doing and why, and to really ask for people's support and encouragement to stick to any of these healthy changes they might make, because as you're saying, sticking to it is really where like the rubber meets the road and how you get good benefit.
Mhm.
So as we start to wrap up, I'm curious, what would you hope that listeners take with them from today?
This can be a very helpful and temporary change in your life. And I will echo what you were saying. It may not need to be, a full-fledged collecting sleep diary. Maybe you just decide, on this weekend, I'm not going to sleep in. I'm going to set my alarm, even though I don't have to get up and go anywhere. What does your day feel like? What is it like when you go to bed that night? Just very small changes to see how you respond.
We are so appreciative of you sharing your wisdom with us today. And I know that this topic is going to resonate with so many listeners. And so if it did, please share this video with somebody that you care about. You also can find resources from our discussion today in the description of this video. And you can also comment, like, and subscribe to our channel. You can listen to the podcast on YouTube, Spotify, and Apple. Also, you can message us on our YouTube, Facebook, Instagram, or LinkedIn pages with suggestions of questions you'd like us to discuss in future episodes.